Hey guys, it's Miss Buck. Today we are going to be talking about pacemakers, defibrillators and defibrillation, cardiac ablation, and ACLS protocols. Alright, so those are your objectives. You can look through those. If you have questions, let me know. Okay, so first off, we're going to start talking about pacemakers. So the goal of pacemaker therapy today is to simulate as much as possible a normal physiologic cardiac depolarization and conduction. A pacemaker is simply just an electronic device that can initiate the heartbeat when the heart's own electrical system can't or it doesn't effectively generate a rate which is adequate to support cardiac output. We will emphasize temporary pacemakers because critical care nurses typically manage those. In the clinical setting, these, like this one on the screen, is like an implantable pacemaker. So we're going to really hit hard on the temporary pacemakers because those are going to be the ones that you likely are more to deal with in a critical care setting. From time to time, we do get these that we have to interrogate or sometimes we have to figure out if they're MRI compatible and things like that. But a lot of the times patients will have cards that they can provide you with or that they keep in their wallet, or if it's at the same hospital, then there will be a record of it in their chart and you can easily look it up to see what type of pacemaker it is. Okay, so intrinsic pacemaker. So our SA node is the pacemaker, it's referred to as the pacemaker of our heart. So for conduction, our impulse begins in our SA node and it causes our atria to contract. That impulse then moves on down to the AV node and then down to the bundle branch, and that causes our ventricles to contract, right? So these electrical impulses are generated by the heart and they travel along a specialized conduction pathway. They allow for blood to pump effectively. I think that needs to be allows the heart to pump blood effectively. It's a typo. I'm so sorry. And then diseased tissue can prevent impulse generation or conduction. So obviously our SA node is our natural pacemaker of our heart in a normal healthy person. Sometimes it fails and then we have to insert a temporary pacemaker or sometimes a permanent pacemaker. Sometimes ablations are needed to help the SA or whatever node is being affected or area of the heart to start working properly again. Okay, so this is just kind of a little quick anatomy review. If you need it, please review it. Like I said, the SA node is our pacemaker of our heart. Our AV node is then located between our atria and our ventricles. And then from there, the impulse is slowed so that it allows time for ventricular filling during relaxation or ventricular diastole. And as you can see, there's a little diagram up here. It gives you your normal heart rates, fast heart rates, slow, and then irregular heart rates. And then this is our EKG. And I know Mr. Harmon is going over EKG, 12-lead EKGs with you on Wednesday. So sometimes it'll kind of help everything click a little bit better once you... Okay, so the evolution of the pacemaker. So the first pacemaker was developed by Paul Zoll in 1952, and it was mainly used in emergency type situations. So the patient had lead wires attached to like a little belt, and then the pacemaker was plugged into the nearest wall socket, and then a shock was delivered that stimulated the heart of the patient that was having an attack or needed to be shocked. So that stimulation would usually be enough to cause the heart to resume to its normal function. And then it basically helped pave the pathway for modern day pacemakers. So we can see from 1958 way over here that it was a little bit big, a little bit bulky. Let me see, 1981, we're getting about the same-ish size, and we're smaller, got a little bit bigger, but now this is the world's smallest pacemaker. So they actually put this here, in here at St. Bernard's. Dr. Nair was one of the first people to do it. She's wonderful. She's awesome. But these are literally as small as they can get them today. And if we look back over here, they're a lot smaller. So the first actual implant of a pacemaker was done in 1958. So this is the first one that was ever implanted. Okay, so why do we need pacing? So we pace for several different reasons. For Brady dysrhythmia, so this can be sinus bradycardia and arrest. It can be sick sinus syndrome, which we'll talk about here in a little bit. Heart blocks, tachydysrhythmias like SVT, or ventricular dysrhythmias like VTach, Defib, things like that, that are long-term problems that people have. My mother-in-law is actually fixing to have an ablation and possibly a pacemaker put in because she had to wear a Holter monitor for a couple of weeks. She was having some problems, felt like her heart was going to beat out of her chest. Come to find out, she's got, she keeps throwing bouts of VTach plus AFib. So there's kind of a conjunction of there, but Dr. Nair is actually going to do her procedures, so she very well may end up with the world's smallest pacer at some point. Permanent pacemaker failure. So if people have a pacemaker already, sometimes they do fail and we have to physically pace them. It can be congenital or degenerative heart disease. So that SA node, remember we talked about the SA node is our pacemaker of our heart. If it fails, we've got to pace. And then obviously support of cardiac output after cardiac surgery. Sometimes they use these in diagnostic studies like EP studies and then atrial electrograms. So we can also see pacemakers used in people who maybe have drug toxicities, maybe they've overdosed on something, and that's affecting their heart. People who have certain electrolyte imbalances, already said after cardiac surgery to help with the cardiac output. And then sometimes they have problems after they've had an acute myocardial infarction or a heart attack that requires a pacemaker. The most common types of arrhythmias include second-degree AV blocks, third-degree heart blocks, and then sick sinus syndrome. Honestly, the most people that I have personally ever had to pace have been third-degree heart blocks. They come in, their heart rate's, 20, 30s-ish or so, and it's like, oh, yeah, you're definitely in a third-degree heart block, and you look at their EKG, and it's like, okie dokie, we need a pacer. So a lot of the times, unless the patient is just completely unstable, we will temporarily pace them in the ICU overnight, and then typically they'll go down the next morning and get an actual pacemaker put in, and then everything's fine. They go to the floor and, go on about their merry way. When dysrhythmias are unresponsive to drug therapy and the result really compromises a patient's hemodynamics and your heart's just not beating as fast as it needs to, this is when we really see the pacemakers come in. So like I said, those heart blocks, we've got 20s and 30s, things like that are going to require us to pace people. Okay, so this is an example of sick sinus syndrome up here. So basically with sick sinus syndrome, you get really, really tacky, you pause, and then you go Brady. You get really, really, really tacky, you pause, you Brady. So we're literally doing all the things, and it's just kind of overloading our heart. So we put in a pacemaker to help pace it and keep a normal, steady rhythm and not bouncing all over the place. Okay, so what are the benefits of cardiac pacing? So the benefits really include just a maintenance of the regular heart rate rhythm, which is going to increase in your overall cardiac output. So that's obviously going to help you benefit from an overall standpoint. It really helps improve that perfusion because of that cardiac output to all of your organs and your tissues. So that improved perfusion is also going to improve oxygenation to our tissues, which in turn provides relief from pain and other symptoms that are associated with oxygen imbalances. But if we use pacing unnecessarily, it can also lead to worsened outcomes that include things like heart failure, new onset AFib, and it really just increases our mortality rate. Okay. So these are just some examples of some modern day pacemakers. I know that I showed you guys the the world's tiniest one that was just brought up and kind of implemented really starting in 2013. But your older patients who obviously had pacemakers put in prior to 2013 are probably going to have something similar to this. So Medtronic, Boston Scientific, those are the two big pacemaker like company type people that deal with like interrogating your pacemakers and handle everything with them if your patient comes into the hospital and they're having problems. So obviously modern pacemakers come in a variety of shapes and sizes, and it's really modern technology has really allowed for advancements in pacemaker technology. So the microprocessors allow for increasingly smaller generators, even though the functions are still very complex. They're a lot more energy efficient and reliable than previous models. And then this is a picture of a pulse generator, and the pulse generator is the power source. So many modern pulse generators weigh about an ounce, and they contain a really, really powerful battery and electrical circuits as well as computer memory. So these literally are mini computers in a way that sit in your body. When you interrogate them, I say interrogate, so basically Boston Scientific or Medtronics or whoever the pacemaker company is, you can call them. There's usually like a little box that you have to use to interrogate the pacemaker, and then they fax over the results. But they can pull data from months and give you an idea of what's been happening in the patient, how many times it's fired, when it fired. It's very specific. So they, in a way, are little computers that kind of monitor your heart and give us a feedback when we need it. So these are usually implanted kind of below the collarbone of a patient, and you'll typically see like a little bulge. And if you ever do, just know that it's a pacemaker. So even if your patient comes in unresponsive and can't tell you anything and they're by themselves, you start cutting their shirt off and, stuff like that, and you see a little bulge, then you know that they probably have a pacemaker. Now, obviously, if it's like a super modern one, like the one that we started using in 2013, you're probably not going to be able to see that one. But these ones are a little bit more noticeable, so it's a little bit easier to tell. All right. So unipolar and bipolar leads. So pacemakers can either be unipolar or they can be bipolar. So we've got either one or two different leads that we can use. So we've got our pulse generators, and then we've got our pacing leads, which are these. It can either be 1, 2, or 3 electrodes. Most of the time you're either going to see unipolar or bipolar. So that pulse generator right here is going to send or create and send an electrical circuit that travels through that pacing lead. So it's going to start from here and go down this lead. And that lead is in direct contact with your heart. So that electrical current is what's going to initiate a myocardial depolarization, okay? So the current is then going to be returned to the pulse generator, and that's how we're going to complete the circuit. So that is with a one lead unipolar circuit. So in a bipolar or 2 electrodes, so like down here on the bottom, okay, we've got a positive and a negative side. Obviously, a bipolar, we got to have positive and negative. And they are located within the heart still. So the positive electrode is approximately 1 centimeter from the negative electrode, and it's attached to the positive terminal of the pulse generator. So with unipolar 1 electrode leads, they are negative, and it's in indirect contact with the myocardium, so the actual heart tissue. In both systems, the current flows through the negative terminal of the pulse generator and then back down the lead paces to the negative electrode and then to the heart. So the current is then picked up by the positive electrode or the ground electrode and then flows back up to the lead to the positive terminal of the pulse generator. So it basically just makes a big circle. It goes in one, through, and out the other. But in both systems, the current flows from the negative terminal of the pulse generator down the pacing lead to the negative electrode and into the heart. The big difference between unipolar and bipolar is just how the current returns to the pulse generator. Okay, so this is what a modern electronic external pacemaker looks like. This looks identical to what we used at St. Bernard's and at NEA. Other hospitals may use different types, but this is just the one that I've seen used around here. Okay, so this is a diagram of an electrode, which is the exposed portion of the wire that is in direct contact with the heart. So that electrode is in direct contact with that myocardial tissue, okay, that heart tissue. Its purposes really are to deliver the current that it has from the pacemaker to the myocardium from the pulse generator. And it senses the patient's intrinsic electronic cardiac signals. All right. So this is a transcutaneous pacing lead and then just a regular pacing lead. So the pacing lead really is just a insulated wire that's used to transmit electrical currents from the pulse generator to the myocardium. So with transcutaneous pacing is going to sit on the outside, okay? Whereas a pacing lead with an internal, even a temporary internal pacer, is still going to be implanted, okay? Okay, so these are unipolar generators and bipolar generators. I know I talked about this just a second ago. So obviously, big thing here is they've got a pulse generator, which is the power source, so it's going to be this little block-looking thing right here, the big part. And then they've got pacing leads. They can have 1, 2, or 3. Unipolar, bipolar are the most common. And then we've got the patient's body tissue. So basic laws of electricity require that an electrical circuit or current complete its full circuit by returning to its source, which is why it sends out the pulse or the electrical impulse to the pacing lead with the electrode, and then it sends it back to the source. That's why we do things that way. So let's kind of consider how this occurs with a unipolar generator, right? So the electrical current moves from the pulse generator through the negative pacing lead to the negative electrode and into the cardiac tissue. The pulse generator itself then serves as the positive pole to complete the circuit and return the current to the pulse generator. Okay, we see how that makes a big circle? So the circuit over which the unipolar pacemaker has to travel is large because of the greater distance between the two poles, which results in a large pacemaker spike on the EKG. So you can see here on this EKG, the spike is where that pacemaker is initiating, okay? And then over here, so it's a lot bigger on a unipolar. On a bipolar, it's a lot smaller. So in a bipolar system, we've got a negative and a positive electrode that are in contact with the patient's heart, right? So that pulse generator initiates the electrical impulse that then travels from the negative lead, exiting out of the negative electrode to the patient's heart. The electrical impulse, or the current, then returns the positive electrode, completing the circuit, okay? So that circuit over which the electrical current travels in the bipolar system is a lot smaller because we've got not one, but 2 different electrodes that we're utilizing. And they're a lot closer together in the cardiac tissue, so they just don't have a lot of room or far away to travel. Okay, so these are some important terms that we need to know when we're talking about pacemakers, and we need to understand what they're doing. So first we're going to talk about voltage. So voltage is the potential force capable of doing work. So battery voltage, for example, is a function of the amount of charged material that is placed inside that battery by the manufacturer. So if you've got like a 9-volt battery, it should be charged with 9 volts, right? And then those volts deplete as the battery dies. Lithium batteries are the most common used for permanent pacemakers, and they're typically 2.8 volts. All right, so what does voltage do? So voltage pushes electrons out of the battery. So the higher the voltage, the greater the push on electrons. We're going to use a garden hose as an analogy here to kind of help understand the concept. So the comparison here is if you have the faucet turned on low or high. The higher it's turned on, the greater the force, right? Okay. The lower it's turned on, the lower the force it comes out. All right. Next, we're going to talk about resistance. So what is resistance? So resistance is opposition to the current. So what can slow or stop the flow of the current? All right, so we're going to continue our garden hose analogy. So if the resistance is normal, then the current is also normal, right? When there's low resistance, the current is high. So low resistance, nothing is trying to stop the flow. So that current is high, right? When there's high resistance, so like a kink, the current is low because we've got a lot of force trying to stop the current, okay? So current is a flow or movement of electrons along a conductor in a closed circuit. Resistance is the frictional force that opposes the flow of that current. Current and resistance have an inverse relationship, so the lower the resistance, the higher the current. The higher the resistance, the lower the current. Resistance is primarily a function of cardiac tissue and the position of the electrode, and it's measured in ohms. So the normal range of resistance or opposition to the current for a cardiac pacemaker is 300 to 800 ohms, and a lead that is functioning properly has very little resistance. Okay, so what is current? I kind of touched on this just a smidgen on the previous slide. So current is the flow of electrons from the battery or the pacemaker generator. So in our garden hose analogy, if you have high current, you have a lot of electrons flowing. If you have a low current, you have a low number of electrons flowing. Current is a result of voltage. So when we're thinking about current versus voltage, current is a result of the voltage, okay? Remember that voltage is the force that pushes electrons out of the battery. So the movement of these electrons is the current. Current cannot be pulled or programmed, and it can't be changed directly, but it can be changed, or it can change by the voltage or the force we indirectly change the current with, okay? So the greater the push, the greater the flow. All right, Ohm's law is basically just a formula that states the relationship of voltage, current, and resistance to one another. So voltage is V, which equals current, which is I, times resistance, which is R. And if any two variables are known, the third can be calculated. When the patient's pacemaker fails to stimulate a depolarization, we attempt to determine which of these components of Ohm's law of the problem exists. So is it a problem with voltage? Is it a problem with current? Or is it a problem with resistance? Okay, so next we've got capture. So capture occurs when the appropriate waveform is present following the pacemaker spike. So Capture indicates a depolarization of the cardiac muscle that follows the electrical impulse that occurs, or the electrical stimulus. This slide really just depicts a capture of both an atrial pacemaker spike followed by a P wave, and then a ventricular pacemaker spike followed by a QRS complex. So remember, I said if your atria is being paced, you need to have a P right after it, or right after your spike. If your ventricle is being paced after your spike, you should see the QRS. And you can kind of see that. Here's our spike, here's our P wave for our atria, here's our spike, here's our QRS. All right, sensitivity. So modern pacemakers really are able to sense the patient's intrinsic cardiac electrical activity. So the pacing generator is then programmed to really act accordingly. So the degree that the pacing system sees or senses the intrinsic electrical activity is known as sensitivity. Really, this function is controlled by the sensitivity setting, and it's graduated, or it's measured in millivolts. I'm sorry. We really want to see pacemakers, we really want the pacemaker to sense when the heart has an intrinsic electrical current so that it doesn't fire when it's not needed. Because if it fires when it's not needed, that can also cause issues. But we also don't want the pacemaker to misinterpret the information and it receive an intrinsic electrical current and not do anything when a pacing impulse is needed. So it's really important that the sensitivity on these be correct. Okay, so we've got three main types of generators. We've got asynchronous, demand asynchronous, and then a dual chamber. So the asynchronous generator delivers a pacing stimulus at a set rate. The stimulus is delivered regardless of the occurrence of spontaneous myocardial depolarization or the patient's intrinsic heartbeat. It is a non-sensing mode, so it doesn't sense anything, it just delivers that impulse or that stimulus. The demand or the synchronous pacer delivers a stimulus to the myocardium only when the heart's intrinsic pacemaker fails to do that. So the function is at a predetermined rate, and in this mode, the pacing stimulus is either inhibited or it's triggered by the sensing of the patient's intrinsic activity, which can involve either the atria, the ventricle, or in some cases both. The dual chamber pacemaker generators are also known as atrioventricular sequential pacing. And they deliver a stimulus to both the atrium and or the ventricle as needed in the physiological sequence with sufficient AV delay, which permits adequate ventricular filling. So these letters are pacemaker codes that we'll talk about here in a little bit when we look at what types of pacemakers they are and try to decipher what's doing what. Okay. So the demand pacemaker senses the intrinsic depolarization and it paces the heart only when the patient's own rate becomes too slow or slower than the pacemaker rate. When the pacemaker senses that intrinsic impulse in the chamber, it inhibits or prevents the pacemaker from sending an impulse. When the pacemaker does not sense an intrinsic impulse in the chamber, it sends an impulse within the allotted time frame so that the patient's heart gets the pulses and impulses that it needs to pump. All right, so an asynchronous pacemaker will deliver a stimulus regardless of any intrinsic activity at whatever rate the pacemaker is set. So it is fixed, it is set, it's going to give it no matter what's going on. All right, so modes of implantation. So how can we deliver? So obviously we've got an implantable one that sits in the patient's heart, and it sits in their myocardium, but we can also have some other types. So we've got transthoracic, epicardial, and then transvenous. Let me go back. So implanted permanent pacer generators are planted just under the skin, as I mentioned before. And a lot of the places they can be seen, usually right under that collarbone. Transthoracic implantation is not commonly used in adults, but patients that aren't candidates for transvenous implantation are usually the ones who benefit from this. So, for example, if you've got a patient with superior vena cava syndrome or subclavian vein obstruction or thrombosis, they're probably going to benefit more from it. The approach for implantation is through a right parasternal mediastinotomy into the right atrium. It has to be done under general anesthesia. I've never seen one of these done, but like I said, it's not typically really common for adults. So you may see it more in like pediatrics or people who just in an adult world have some kind of problem, like I mentioned, and they're not a candidate for other ones. Epicardial implantation is a less commonly used method of permanent pacemaker placement. It requires the patient to be put to sleep, and the recovery time is just really, really prolonged. Really, with that type of implantation, it's most often used in children and for adults that need open heart surgery at the same time as they need a permanent pacemaker. In this method, the pacing leads are attached to the outer surface of the myocardium, either during open heart surgery or through an incision just below the rib cage. So with transvenous implantation, it's really the most commonly used one. It just has less complications than transthoracic placement. And the way that we insert a transvenous catheter, or how we implant it, is through an incision that is in a vein, which is usually either like our IJ, our internal jugular, or our subclavian vein. And then it's guided to the heart under fluoroscopy. So it just lets the physician see exactly where they're going. So that tip is then attached in the heart in the right area that it needs to be in, of the endocardium or the epicardium. And then transvenous implantation is usually done under local anesthesia. So this is just a drawing of epicardial pacing lead placement. And then this diagram indicates where the lead placement will be in single chamber, dual chamber, or biventricular pacers. So placement of the right ventricular lead typically occurs through like the tricuspid valve, as long as the valve is healthy and nothing's wrong with it. And then the left ventricular lead is usually placed through the coronary sinus vein, and then down into the epicardium. This just indicates the differences in placement of the transvenous and epicardial approaches. And then this is just another picture of the world's smallest pacemaker. So I left the article for St. Bernard's when they first put this in. I think it was back in 2017. Dr. Nair did it, and it's just the article about it. It's in the notes section if you guys want to read it. Okay. External temporary pacemakers. So external pacemakers have pace generators on the outside of the body. Remember, our internal pacemakers have that pace generator on the inside, obviously because it's an internal pacemaker. So transcutaneous pacing is one form of external pacing. We've got two large electrodes that are placed on the patient's thorax. These pads, or electrodes, deliver an electrical impulse to the patient's thorax, which stimulates their myocardium. So it's a rapid, non-invasive procedure that honestly nurses most of the time perform in an emergency and when it's appropriate for certain patients during codes. It's used for short-term use, and it's typically pretty painful and can honestly cause burns to the patient because if you think about it, it's just constant electrical impulses sitting on their skin through a pad. When the patient undergoes cardiac surgery, epicardial pacing wires can be placed, and they're usually bipolar leads with two separate wires that are insulated and loosely secured to the epicardium of the chamber that's being paced. Both leads are loosely sewn to that myocardial tissue, so either can be used as the negative pacing electrode. So the other wire is then used for a positive or a ground electrode, and the leads are pulled through the skin before the chest is closed up. Atrial leads exit on the right side of the sternum below the ribs, and ventricular leads exit on the left side of the sternum below the ribs. So atrial is right side, ventricular is left side, both under the ribs. Transvenous endocardial pacing is done by advancing an electrode wire through a vein. It's an internal temp pacemaker, usually the subclavian or the internal jugular are the most common. I just mentioned that earlier. The lead is floated into the right atrium or the right ventricle for pacing, and generally speaking, temporary pacing is indicated when the patient is symptomatic from a slow ventricular rate. It's important also for us to note that before permanent pacemaker insertions are even considered, we have to be sure that the problem cannot be resolved through medical treatment. If it's something we can fix with a med and the patient's good, then we're okay. But if it's something that truly needs a pacemaker and can't be fixed medically otherwise, then obviously we have to do what is necessary. Okay, so this is a diagram of electrode placement for transcutaneous pacing. This is an old, when I say old, I mean old, defibrillator, pacer, however you want to say it. They used to have one of these in St. Bernard's ICU, and we called it Bumblebee. And honestly, I literally never had to use it, and it terrified me because I really wasn't 100% sure even how to use it, because literally we never used it. And now everything is all in one in the Zoles. So when they switched over and got Zoles, they got rid of Bumblebee. So 2 large electrode pads are placed on the patient's thorax, and the defibrillator pacer is set to deliver a stimulus at a set rate with these. This is for temporary use only, and the patient, like I said earlier, is probably going to experience some pain, mild discomfort, mild to moderate discomfort, and it's probably just not going to be the most comfortable thing, and they very likely are to end up with some type of like burns just because of the electrical impulses that are constantly going straight to their skin. All right, so this is important. This is very important. I need you to really, really study this chart. So the Inter-Society Commission for Heart Disease originally adopted 3 different letter codes describing the various pacing modalities that were available. There have been 2 different revisions since then that represent programming characteristics and multi-site pacing functions. So position 1 is the chamber or the chamber's pace. So we see position 1, 2, 3, 4, and 5. Okay, position. Down here we see the category. I really wish that would go away. We see the category. So it's got the chamber's pace, chamber sense, response to sensing, programmability rate modulation, and then the anti-tachyarrhythmia functions. So with position 1, it's chamber's pace, position 2, chamber's sense, and so on and so forth. We'll talk about it a little bit later as we get on into the slides. It's really helpful to know that the 3-letter code is still adequate for temporary pacemaker function as well. And then positions 1 through 3, as down here, are used exclusively for anti-bradyarrhythmia function. Okay, so pacemaker code, position 1, chamber pace. So the letter listed in position 1 refers to the chamber that is paced. So A is atria, B is ventricle, D, think dual, atria and ventricle, and then 0 is none. Chambers sensed on position 2 are atria is A, ventricle V, D is dual, atria and ventricle, so double both, and then 0 is none. 3 is different. It's mode of response. So I is inhibited, T is triggered, and then D is dual, or both I and T, okay? So position 3 really just indicates the pacemaker's response to the sensed event that occurs. So depending on the event, the pacemaker is either going to inhibit a response or it's going to trigger a response, okay? So for example, if a P wave is sensed, then atrial pacing would be inhibited. Or when a P wave is sensed, ventricular pacing is triggered. So position 4 describes two different device characteristics. They are the degree of programmability and the presence or the absence of an adaptive rate mechanism. So 0 is none, so nothing happens. So it indicates that both the device is not programmable and it possesses no adaptive rate feature. P is simple, so its rate, output, and sensitivity have one or two programmable parameters. M is multi-programmable, so more than two programmable features exist. And then C is communicating, which means that the device possesses telemetry capability, so we can literally see the actual waveforms and EKG. And it also implies that it is multi-programmable. And then R is rate modulating, which indicates adaptive control of escape interval. So if the heart rate is excessively high, it can pace at a faster rate, essentially, than the intrinsic rate. And then it can attempt to slow down the patient's heart rate if it's too fast. These rate modulating devices are programmable as well. And then position 5 is used to indicate the presence of one or more active anti-arrhythmia functions, pace, shock, or dual. So if it senses and it senses what it's supposed to, it can either say, hey, you need to pace, hey, you need to shock, or hey, we need to do both. So in ventricular demand, VVI, there is both ventricular sensing and pacing, and the pacing is inhibited if an intrinsic ventricular beat is sensed by the pacer within a specific time. In atrial demand, or AAI, the atria both senses and paces, and the pacemaker is inhibited if an intrinsic atrial beat is sensed within a specified time. For AV sequential, or DVI, this both atria and ventricles are paced, but only the ventricle is sensed. So the pacer is inhibited if an intrinsic ventricular beat is sensed. So fully automatic mode is DDD. So both the atria and the ventricle are paced and sensed. Both trigger and inhibited responses are activated. If no intrinsic beat is sensed, then the pacer chamber, or sensed, then the chamber is paced. So if no intrinsic beat is sensed, then the chamber is paced. I'm getting tongue-tied. A sensed P wave in the atria will inhibit the atrial pacing spike, and a sensed R wave in the ventricle will inhibit the ventricular pacing spike. So there's an inhibited response to the pacing stimuli to sensed events in their respective chamber, and there can be a triggered response to sensed atrial activity to allow for rate responsive ventricular pacing. So some complications that can happen with pacing. So obviously a failure to capture is the biggest one, or a loss of capture. And a failure to sense, or oversensing or undersensing, are also really common. So failure to capture occurs when the stimulus is inadequate to generate depolarization of the cardiac tissue. Failure to sense occurs when the pacemaker oversenses or undersenses the patient's intrinsic electrical activity. And failure to properly sense can result in the patient being paced when they have an adequate intrinsic rhythm, or the patient not being paced when their rhythm or rate are too low. Okay, so first let's talk about failure to capture. Loss of capture can be evidenced by the disappearance of the pacing spike. Okay, so you see our little spikes down here. That's where our pacer is spiking. That's where it's initiating at. Okay. So when we have a failure to capture, that pacing spike disappears, or the appearance of the pacer spike is not followed by depolarization of the cardiac tissue. This can occur intermittently or continuously, and it can be a result of a failure of the generator or its battery, loose connections within the pacemaker system, or a displacement of the pacing electrode. So if this occurs with a patient receiving temporary pacing, we want to make sure our connections are tight, replace the batteries for the pulse generator if needed, or increase the output or milliamps. If this occurs in a patient with a permanent pacemaker, then they may require a temporary pacemaker while we wait for intervention from the cardiologist or the pacemaker manufacturer company. So oversensing, this is an example of oversensing on this little picture. Oversensing occurs as a result of an inappropriate sensing of tall peaked T waves or extraneous electrical signals such as electromagnetic interference. Here the pacemaker sensed the P wave as the QRS, and it inhibited pacing of the ventricle. With undersensing, it is a failure of the pacemaker to sense spontaneous myocardial depolarization. So undersensing can result in the delivery of the pacing stimuli when it's not needed, and it can place the patient at risk of a stimulus being delivered during a relative refractory period. The relative refractory period is what occurs when the downslope of the T wave happens, and there's a real danger that this can precipitate a lethal dysrhythmia. Okay, so pacemakers are very commonly inserted through the subclavian vein. Subclavian veins are utilized very frequently when it comes to pacemaker insertions. This slide really just lists common complications that can occur because of a subclavian puncture. So we've got pneumos, subclavian artery injury, brachial plexus injury, bony spicules on the clavicle. Spicules are just a sharp body with a needle-like point. They're just really pokey. Hematomas, air embolisms, or thrombosis. I do want to point that the spicules can cause injury to the clavicle. Okay, so it says, thank you for calling Happy Beat Pacemakers Technician Support or Technical Support. If your pacemaker speeds up when you accelerate your car, press 1. If your pacemaker makes a loud howling noise when you are near a radio, press 2. If you begin to run uncontrollably when you are near fluorescent lighting, press 3. So when a pacemaker battery starts to fail, the patient can notice a couple of different things. So they can notice inappropriate slowing of the pacemaker rate or inappropriate tachycardia. Really new generation pacemakers and then our automated defibrillators use the patient's telephone to gather data. And it's from like special equipment in the home that they use, such as their scales, their blood pressure equipment. It's all connected. That information is sent to central monitoring systems that then that the manufacturer then sends to that cardiologist. So kind of like I was saying earlier, when we come in and like interrogate it, we can pull months worth of stuff and see what their rhythms have been running and whatnot and all that. So I just thought this was funny because sometimes pacemakers need to be tweaked just to achieve their jobs and their optimal performance. Okay. So it mentioned on there electromagnetic interference. So patients who have pacemakers typically can't have MRIs. Most of them are not compatible. It's also important that patients be aware of electromagnetic interference in their homes. So according to the AHA, modern cell phones don't cause complications with pacemakers, but older phones and newer technologies can present some risk. So it's recommended that cell phones and iPads be kept at least 6 inches away from the pacemaker site. It is safe to pass through like metal detectors, gate, detectors, stuff like that, but patients shouldn't linger. Security metal detectors like those in airports can be passed through at normal rates, and handheld detectors should be avoided. The patient must present their pacemaker ID card when they're in situations like this. Otherwise, it can be deemed as you're being non-compliant and things like that. So it's always important that we encourage patients to keep those cards with them. And then heavy-duty electrical power equipment, such as arc welders, electrical surgical tools, bending over, running car engine, all of those things need to be avoided. Patients should be provided with the package of information from the pacemaker, and it's going to include all of that education on the ID card. Okay. So now we're going to talk about defibrillation. So defibrillation is just the process where a current is passed through the heart and it depolarizes the cells, allows them to repolarize uniformly, and it restores an organized, coordinated impulse and contraction. So in an emergency, we position external paddles as far from the pacemaker and leads as possible. So think like apex and posterior. Really nowadays, we don't really use paddles. We use pads that attach to the monitor, and then nobody even has to touch the patient whenever we shock them. But sometimes they do still use internal pads, like in cardiac surgery. They literally look like little mini paddles, and they go on either side of the heart, and they shock them that way. But it's internal. So we have to, like I said, completely depolarize the heart, allow for the resumption of the rhythm. Safety is the big thing here. Biggest complications, kind of like with transcutaneous pacing, is skin burns, and then we can also damage the heart depending on how many joules we shock at. We have to implement safety checks to prevent shocking to our surrounding nurses, healthcare providers, people like that. So always make sure clear before hitting the shock button, whether it's paddles or with the pads. So external paddles are that traditional way of doing it. We also have the external hands-off defibrillation with multi-purpose pads. These are really the ones that are most commonly used nowadays. And then we have paddle and pad placement. So it's transverse anterior and then anterior posterior. Really, paddles have been used for years, but they require like the gel, and the pads are just so much more efficient at delivering the current, and they're way less messy and provide for a safer hands-off approach. But regardless of the type, the correct paddle and pad placement is important. So like I was saying earlier, we also have internal paddles that we can use that sometimes they're referred to as spoons. They're used a lot of the times in cardiac surgery, cabbages, transplants, things like that, because the heart has to be stopped for a certain period of time, so they have to get it restarted, so they got to shock it. Okay, so it's important that we talk about the difference between defib and cardioversion. So we need to prevent shock on the vulnerable T wave during cardioversion. Defib is a asynchronous delivery of a high energy shock, okay? And cardioversion, and we're going to talk about cardioversions here in just a little bit, but cardioversions involve synchronizing to the QRS complex. And it's really important that we know which one we're doing, because if we do the incorrect one and shock on the wrong part, we can cause a lot of problems. Patient's probably going to code, probably going to go into a funkity-dunkity rhythm, and we're going to be coding them within a couple seconds. So remember, during cardioversion, we need to prevent shock on the T wave. We want to shock synchronizingly to the QRS. With Defib, it's asynchronous. Okay, so implantable cardioverter defibrillators. So the primary prevention is placed for patients who are at risk for sudden cardiac death. And then the secondary prevention is placed for patients who have survived cardiac arrest or sustained ventricular dysrhythmias, or they have a left ventricular ejection fraction of less than 35. So we need to make sure that if our patient has one of these, we know why they have it. They're capable of identifying and terminating those life-threatening ventricular dysrhythmias. The leads contain not only electrodes for sensing and pacing, but also those defib coils that are capable of delivering a shock. The generator in these is typically larger to accommodate the larger battery, and it's still used for, it's still used in conjunction with antiarrhythmic meds as well. All right. So diagram A shows the placement of an implantable cardioverter defibrillator and epicardial lead system. The generator is placed in a subcutaneous pocket in the left upper abdominal quadrant, and in the event of a life-threatening dysrhythmia, the generator can either pace or deliver an electrical shock to cardiovert and defibrillate through those epicardial patches. This system, to be able to have one of these, you have to go through like an open heart surgery, because obviously it's a little bit more extensive to place. Diagram B is the transvenous lead system. So pacing, cardioversion, and defibrillation functions are all contained in a lead, or sometimes multiple leads, into that right atrium and ventricle. So the generator is small enough to be placed in that pectoral area, so usually kind of under the clavicle. Yep, this is just another little diagram. Okay. So AEDs are automated external defibrillators, the one that we're probably most common with or familiar with in the hospital. So AEDs are readily available in a lot of different places. You'll probably notice if you've ever been in the nursing building, we have one on the second floor by the elevator. And I'm pretty sure that Reynolds has one over there somewhere as well. I just can't think of off the top of my head where it's at. But I know that the one here in the nursing building is right next to on the second floor next to the elevator. To use these, training is included in BLS courses, so that anyone can really use the device, and then always ask someone to activate the emergency response system if the device is ever deployed. In a hospital setting, you're always probably going to have extra hands on deck. Somebody else is probably going to be handling it, probably your charge nurse. But if it ever happens like here or out in public and you're using one, it's always just really important to make sure that somebody calls 911 and you get help as soon as you can. So to use these, we use them to defibrillate and to analyze rhythms. So we use them for cardiac arrest, and the procedure is to place 2 adhesive pads. You analyze the AED, it looks at the rhythm, and then it says shock advisory. It tells you shock is needed, shock is not needed. And even the ones in the hospital, the Zolls, when you're doing compressions, it'll tell you if your compressions are deep enough, if they're not deep enough, or if you're doing really, really good. Like, it'll say good compressions, and that is the weirdest thing to hear in the middle of a code. Good compressions, keep going. Compressions are too shallow, or compressions are too deep. Slow down. Compressions need to speed. It literally tells you exactly what you need to know. And it's the weirdest thing when you hear it like the first time in the middle of a code, because you're like, who is saying that? And then you realize it's the AED. Okay, so procedures for defibrillating. So we have our paddle or the defibrillation pad placement. Most of the time nowadays, like I said, it's going to be the pads. Make sure that they've got good contact with the skin. This helps to protect the patient from getting burns. And then if we have the paddles, we want to make sure we have enough gel on them so that we don't burn the patient. We want to charge the defibrillator to the desired setting. And then it's I'm clear, you're clear, everyone clear, oxygen clear. We want to make sure that if we have the paddles, that there's adequate pressure. If the pads are on, they should be made sure when you stick them on that they're on like really, really good. We shock, and then we continue CPR for 2 minutes, and then we assess our rhythm again. So really, it's just a standardized approach for defib. We want to ensure safety. Obviously, it's always the most important thing. And then this is an example of one mnemonic that may be used to ensure that no one person or oxygen is really touching the patient during shock delivery. I'm clear, you're clear, everyone clear, oxygen clear. All right, so this is just an example. It's an older picture of the paddles that we see, and it had like the gel pad medium. Sometimes it was actual gel, sometimes it was like gel pads like this. Really in patients who have really hairy chests, so your guys typically, the pads may be a little bit harder to stick to them if you have time. A lot of times you don't. But if you have time and you can grab the clippers and shave a big enough area off, it just helps get better contact with the skin. It's going to prevent burns. It's going to make sure that that full impulse is getting to the skin and it's not just hanging out in limbo. But like I said, a lot of times you don't. You just try to have to pick a spot that's not as hairy. And it's also really important that anytime that you have a patient with a pacemaker who has had to have any kind of defibrillation, even if it's with their own, that you interrogate the pacemaker, see what happened in the events leading up, and then you're probably going to have to call the cardiologist, and they're going to have to come in and look at everything and evaluate it. Okay, so it is super, super, super important to minimize the time from onset of pulseless ventricular tachycardia and ventricular VFib, so VTAC, VFib. We really just need to make sure that we minimize the time of intervention, was the word I was looking for. So basically from the time they go into it to the time that we intervene, the longer it gets, the chances of success and successfully resuscitating that patient, kicking them out of that rhythm, are reduced 7 to 10% each minute. So by 9 minutes, if we haven't gotten that patient back, even in codes, a lot of the times it's probably not looking very good. And I think that goes for, just using our critical thinking there. The longer we do something, obviously, the more harm and damage and trauma that we're doing to somebody's body. If we can get somebody back after, a couple rounds of CPR, after about that 2 to 4 minute mark, if we can get them back, okay, our success rate's still pretty high. But as you can see, after that 5 minute mark, after about 10 minutes, if we can't get them back, we're probably not going to. And sometimes that's really, really hard for families to understand. I've worked on people for hours before, and the family just was not grasping at the fact that it had been, almost 2 hours and we still hadn't gotten them back, and they just were in denial. So it is really, really, really difficult for patients' families, but I always think it's important to talk about the time frame related to success of resuscitation, because it's not just a super long time. So if people are down, found down, and it's an unknown amount of time, they could have been down for 2 minutes, they could have been down for 2 hours. And if they've been down for 2 hours, the chances of getting them back are probably very slim to none. Okay. So determinants of resistance or to defibrillator discharge. So the major determinants of the resistance to defibrillator discharge are operator and patient dependent. So the influencing factors are the amount of energy delivered. So the output of defibrillation is quantified in joules. The electrode size and composition. So currently there really isn't enough data to recommend a specific electrode size for optimal external defibrillation in adults, but it's reasonable to think and to assume that a pad size or paddle size of greater than 8 centimeters is what needs to be used. The interface between the electrode and the patient's skin, so the use of that liquid gel for paddles or solid gel on electrode pads decreases resistance and prevents burns to the patient's skin, as I've mentioned before. The number and time interval between discharge, so transthoracic resistance decreases by 8% with subsequent shocks. This is why once we get to a certain energy level, we do not go any higher, because more energy would literally be detrimental. Electrode pressure, so really for the pads, this isn't as big of a deal. I mean, obviously make sure that they're stuck on there, but you're not going to be holding them in place. But if for some reason you ever actually have to use the paddles, when shocking a person, you need to have about 25 pounds of pressure per paddle on them. And then the phase of the patient's ventilation. So full exhalation is best. The patient's not breathing, so when we stop providing ventilation, they will be in exhalation. And then obviously just familiarity with and knowledge of the operation equipment to perform defibrillation is super important. Defibrillators are either monophasic or biphasic, and what I mean by that is monophasic machines deliver that electrical impulse or current in one direction, so from one paddle or defibrillator pad to the other. Biphasic machines deliver a current back and forth to each paddle or pad. Biphasic machines are typically the most common ones used in inpatient care and emergency settings. And then during cardioversion, the defibrillator needs to be synchronized to the patient's cardiac rhythm in order to deliver a shock simultaneous to that R wave. To perform defibrillation, the sync mode cannot be activated. So remember I talked about before, when we do cardioversion versus defib, cardio is synchronized, defib is not. So the initial shock when we defib somebody is commonly delivered at 150 to 200 joules if using a biphasic device, and 360 joules if using a monophasic device. Subsequent shocks are delivered at an equal or higher energy, up to 200 joules for a biphasic device and 360 for a monophasic device. So the AHA recommends that CPR is resumed in between shocks rather than administering 3 stacked or back-to-back-to-back shocks, and which was previously recommended. So we shock, we continue CPR for 2 minutes, reanalyze the rhythm. If it's shockable, we shock it again. If not, we continue CPR. Okay, so this is just an example of how this works. So monophasic waveform, so we go from one pad to the other. Biphasic, it makes a circle. Okay, so we go from one pad to the other and back. So it creates a current flow. Okay, so I've mentioned the differences before, but here's a little chart for cardioversion and defib. So Defib is not synchronized. It's for cardiac arrest. We use higher energy joules, and we don't escalate energy for the next shock. Cardioversion, we synchronize on that R wave because we want it to hit on the QRS. It's for peri-arrest tachyarrhythmias that are unstable. So like your SVTs are the thing that I think of if we can't get the patient to convert out with medications like adenosine and reset. I have had to cardiovert people in SVT several times before. It uses a lower energy joule, and we escalate for the next shock. So we start at 100, then 200, 300, and then 360 is our max. So synchronized cardioversion is really the treatment of choice for those hemodynamically hemodynamically stable VTACs and some atrial dysrhythmias and AFib and aflutter and things like that. When the patient is stable, we have time to be able to synchronize that defibrillator to that patient's intrinsic electrical conduction so that we can deliver that shock at the time of the QRS. The patient has to be connected directly to the defibrillator to monitor for synchronized cardioversion so that the defibrillator can detect and mark that QRS complex. And then that allows for the electrical current to be delivered during the QRS, avoiding the T wave, which, remember, is the vulnerable portion of that cardiac cycle. Firing of the defibrillator can be a little odd, but the person who's operating the device when they're shocking has to press and hold the discharge button until the machine discharges, which can take a couple of seconds until the device kind of figures out where it needs to fire. So, Miss Fleming has like a little Zoll monitor, and I'll see if I can get it from her Monday morning and use it and bring it to you guys to like show how we would do that, because it's like, it legit looks like a little Zoll monitor, and you just press it and it does the thing, and you can change the joules. This is how we check to see if, when we check off, if the machine's working right. If it's got an X over here, that means it's probably not working right. This is the off button. This is the pacer mode, and I think this says like Defib or something along like the code button and stuff like that. All right, this picture is very, very blurry, but this is just synchronized shock with the QRS complex. It's cardioversion. So cardioversion, like I said, synchronized. It's an electrical current. We use lower joules, so like 50, 75, 100, and we escalate from there. Synchronized delivery happens on that R wave because it prevents shock on the T wave. The purpose of cardioversion is to disrupt that ectopic pacemaker that's causing the dysarrhythmia to allow that SA node to take control of the rhythm. Lower joules are used, like I said, to prevent shock on the T wave. So this is a pericardial thump or precordial thump. Really, this is not used anymore. I've never seen anybody use this. I'm really not sure why we cover it. Maybe you'll see an old ER doctor use it one day because, you know, they still got all the tricks up their sleeve. I have had a couple of people tell me that they've seen this used. So basically, you just make a fist and you like super, super quickly thump. I don't know how else to say it. A patient's sternum with your fist. So it is all right to do it if you witness a cardiac arrest and a defibrillator is not immediately available, or if you know how it works for the patient. Some people will convert from BTAC with a thump. It's kind of equivalent to about 4 to 8 joules if it's done right. You can't time it, so if the blow lands on a T wave, then the rhythm could deteriorate, so it's really not recommended. But I guess if you're in a pinch and, you know, out in the middle of nowhere and somebody just falls over next to you and it brings them back, then, hey, you've saved them. But if you're in a hospital setting, this is probably not going to be used. And this is very much not recommended for pediatric patients just because they are so much more sensitive and their bodies are so much smaller than actual adults. Okay, And then lastly, we're going to talk about cardiac ablations. So this is really just a procedure that corrects heart rhythm problems like arrhythmias. It works by scarring or destroying that tissue in your heart that triggers or sustains an abnormal heart rhythm. And in some cases, cardiac ablations prevent abnormal electrical signals from entering your heart, which then stops the arrhythmia. So my mother-in-law, I told you guys earlier, has been going in and out of like VTAC and AFib, A-flutter, all that good stuff. So she's actually going to have an ablation and possibly going to end up with a pacemaker in a couple of weeks. So she was telling us about all this, and I was like, yeah, you're probably going to have an ablation. And then she went to Dr. Nair, and she was like, yeah, you need an ablation. And I was like, it's like I knew what I was talking about for just a second. But no, it's super common procedures, typically done outpatient. It's most of the time not anything just overtly complicated. Sometimes they will have patients who, for whatever reason, during the ablation, I have had people code before. They've been in cath lab getting the procedure done, or they've been in outpatient surgery getting the procedure done, and then all of a sudden you hear code blue, cath lab 2, or code blue, outpatient surgery, or whatever, and it's someone who's had an ablation and just their body, like nothing went wrong with the procedure, but their body just reacted differently, and yeah. So sometimes that does happen, and so sometimes you very well may get a patient who's had an ablation post-arrest, because I've had it happen just a couple of times. So when we do ablations, or I say when the cardiologist does ablations, they use a long little flexible tube like a catheter that's inserted either into a vein or an artery, usually in your groin, and it's kind of threaded up to your heart to deliver energy in the form of heat or extreme cold to modify the tissues in the heart that cause that arrhythmia. It's sometimes done through an open heart surgery, but it's often done using those catheters because it makes the procedure less invasive and it shortens the recovery time. They're used to treat those abnormal heart rhythms, so arrhythmias, when medicines are either not effective or they're not tolerated. And then medicines help to control the abnormal heart tissue that cause arrhythmias, but catheter ablation really just destroys the tissue. It's a low-risk procedure. It's successful in most people who have it. Procedure takes place usually in EP, cath lab, so electrophysiology or cath lab. I know a lot of times they're together. Outpatient surgery type centers, places like that, takes about 2 to 4 hours. It's not very long. The most common rhythm that requires an ablation is SVT. And then catheter ablations are also used to help control things like AFib and A-flutter. And then catheter ablation, they just destroy that abnormal tissue without causing damage to the rest of the heart. Okay, so I'm going to stop there because this has been quite long, and we will cover the rest of the material for rapid response teams and code management on Monday. So we'll do a little bit of a review of this. I'll go over, I really need you guys to know your pacemakers, the settings, what the difference is between defibrillation and cardioversion. Those are the major things I need you to know. And then we'll go over all of this on Monday. I think the rest of it's about 30 slides. It shouldn't take too long, but I know that you guys have literally watched almost an hour and a half of a recording, so I don't want to put too much on you over the weekends with it being Easter and everything. So enjoy your weekend. I really hope everybody has a good Easter weekend. If you have any questions, feel free to email me. I will check it periodically, but if I don't hear from you guys, I will see you Monday morning.